Welcome to our week 4 of Series 5. My name is Anna Forendran. I'm the Executive Manager from ICANN based in Cape Town. And I really want to just ask if everybody can please keep their mics muted, their videos off. If you do have any questions, please post them in the Q&A box and not in the chat box. It's easier for us to respond on the Q&A box as well. We will go through the program, and at the end we will respond to the questions that we couldn't respond by email quickly. We will have a panel of discussions, and we want to also welcome the different experts from WHO, AFRO, WHO, IMRO, CDC, Resolve Safe Lives, even the people from Zimbabwe BRTI, and everybody from Africa CDC and Africa Union. Thank you very much for your time spent to try and assist us with this. We want to go ahead with the recommendations for healthcare facility leadership and management in the context of COVID-19. And I want to first introduce Dr. Patrick Wabe, who is going to do the introduction on COVID-19 status in Africa. And I'm going to stop sharing my screen so that he can start with his presentations. Welcome, Dr. Patrick.
Right, thank you, Anne. Let me just share my screen. Okay, I hope people can see my screen.
Yes.
Okay. Just All right, good morning, good afternoon, colleagues. So this afternoon, I'll take you through the epidemiological updates of COVID-19. So on this slide, as of 9 a.m. Eastern African time today, over 106 million cases and 2.3 million deaths have been reported globally, giving a case fatality rate of 2.2%. And Africa accounts for 3.5% of the total cases that have been reported globally. So this slide is showing the trend of COVID-19 cases from February 2020 to date in Africa. So over the past 3 weeks, there has been a downward trend, which is explained by reduction in daily new cases being reported from the southern region, specifically South Africa. However, the case fatality rate has been increasing in Africa and is currently at 2.6% as of 10th of February. And this is higher than the global average of 2.2%. So cumulatively, over 3.6 million cases have been reported, over 96,000 deaths, and 88% of the cases have recovered in Africa. So this table showing the distribution of COVID-19 cases, deaths, and recoveries by AU regions. So in the last 24 hours, over 9,000 new cases, 603 deaths, and over 11,000 new recoveries have been reported from 55 member states in the 5 regions. So it's also important to note that the total number of reported new cases and deaths fell by about 25% and 28% respectively. That's between the AP week 4, that is between 25th to 31st January, and AP week 5, that is 1 to 7th February. And excluding South Africa, reported new cases and deaths decreased by 16% and 17% respectively. So this slide is showing the COVID-19 case fatality rates by AU member states. So there are 5 categories here. So 24 countries have a case fatality rate that is between 1 to 2.2%. 17 countries have a case fatality rate that is between 2.2 and 5%. 10 countries have a case fatality rate that is less than 1%, while 3 countries have a case fatality rate greater than 5%. And these are the Sahrawi Republic, Sudan, and Egypt. And finally, I'll take you through the testing that we've conducted in member states. So over 32 million tests have been conducted across the continent. The overall positivity rate has not changed from last week and currently at 11.4%. And the overall test per case ratio currently stands at 8.8 tests per reported case, which is lower than Africa CDC recommended range of 10 to 30 tests per case. And this might actually indicate that many cases are likely going undetected on the continent. So I'll end here. Over. Thank you.
Thank you very much, Dr. Patrick. It's great to see that at least we can see the drop down happening and the recovery rate. Next in line, I want to just also welcome Amy Elizabeth Ferreira Candesa. I'm not saying it as well as she does, but Amy's been before on the call. And Amy is an IPC specialist, and she's now starting working with Resolve to Save Life, previously with WHO Afro. I'm going to hand over to Amy, or Edith as we know her. Edith, over to you. You're still muted. Just unmute yourself.
That would probably be helpful. Thank you, Anna. Good morning, everyone. It's a pleasure to be back with you today. Again, thank you, Anna, for that warm welcome. I always just wanted to show people what I look like, so that way you have an idea of who's actually talking to you when we're giving these presentations. But I won't make you look at me the entire time. I just wanted to say hello and thank you so much for coming today. So I am going to talk about something that's very passionate to my heart in terms of infection prevention and control. And we're going to go back and talk about administrative precautions again today. So let me turn off my camera and I'm going to start sharing my screen. Can everyone see my screen okay?
Yes, if you can just make it a slideshow, then that's
there we go. So today I'm going to talk about, again, sort of the theme for our webinar series has been giving some critical guidance to, healthcare facility leadership, management, and decision makers. And today we're going to talk about the following things. So we just heard from Dr. Patrick, the epidemiological situation in the Africa region. I like to be very interactive during my training, so I'm going to ask all of you to please participate in an icebreaker with me. And then today we're going to talk about administrative precautions again, because those are some of my favorite precautions and some of the most important precautions that we can implement as healthcare leaders and managers at healthcare facilities, to make sure that we're doing everything possible to try to change our behavior to ensure we reduce the transmission of COVID-19 or any other pathogen we may be experiencing during an epidemic or pandemic. So I am going to give you an overview of the triage process and why it's important. I'm going to talk about the minimum requirements for establishing triage at your healthcare facility. And then I want to talk a little bit about screening and its significance, and then the minimum requirements for screening. And then we're going to have an additional discussion on sort of budgetary considerations for IPC, and then a really delicious panel discussion at the end. So here are the training objectives for the overall webinar series. I won't go into these too terribly much because we discussed these extensively in our first session. But these are the guarantees that we provide to you that at the end of this webinar series, you should be able to very comprehensively and with passion and confidence be able to answer and identify these different training objectives. So let's do an icebreaker. Okay, everyone ready? Is everyone warmed up? Everyone's excited about IPC? Can't wait to talk about it? You eat, breathe, and sleep it as much as I do? Okay, well, here we go. I would like you to answer this question by putting your responses in the chat box for me. So the first question is, what are administrative infection prevention and control precautions? What are they? If you could just type your response in the chat box, and then we're going to talk about it a little bit. So we hear this word all the time during COVID-19. We hear it, we use these words a lot. Traffic flow restrictions. I see someone type traffic flow restrictions. Okay. I think that's referring to just really being mindful and monitoring people coming in. Hand hygiene. Okay, I see hand hygiene. Policies and guidelines, basic measures for IPC, policies, logistics. Okay, really good. So, administrative precautions, just to refresh everybody's memory, are a set of infection prevention and control precautions that we use to try to change behavior. So hand hygiene and wearing masks and disinfection processes. Those are what we would call what? Hand hygiene, disinfection, wearing PPE. What kind of IP precautions are those? Exactly. Thank you, Aman. Look at Aman. I see Umar, very good. So we have, those are standard precautions. Those are the basic infection prevention and control practices we would want to have in place in our healthcare facilities. There's another set of precautions that we use called transmission-based precautions, where we're using specific IPC practices to reduce or minimize the actual transmission of a specific pathogen. Administrative precautions are unique, and they're my favorite set of precautions because they are the precautions that really take IPC one step further, in my opinion, and that they really are, they've been developed to change behavior of health workers or other people who work in a healthcare facility to make sure that they and the patients they care for are safe and don't become infected with the pathogen. So who can give me, please type in the chat, I saw a couple of examples, but who can give me some examples of administrative precautions that we use during COVID-19? Remember, there's prizes for correct answers. You get big virtual hugs from eBeth. I'll give you a big virtual hug for those who can get it correct. I see policies, social distancing policies, training. I love it. Sick leave policies. Monica, you're making me very happy. Isolation, triage, SOPs. Okay. So this group is on it. So the two administrative precautions we're going to talk about today are triage and screening. These are two very important precautions during an epidemic or a pandemic. And I wanted to spend some time with you this afternoon talking about these two things because they are often easily confused and used interchangeably. And they should not be used interchangeably. So I just wanted to talk a little bit about that and get your icebreaker thinking caps on for IPC. Okay, let's get started with the content. All right, so I just told you what exactly are administrative precautions. They're those that really want to change behavior, and all of you were brilliant. You said that they're training, their procedures, their policies, basically anything that can reduce the threat of an infectious agent and change people's behaviors to reduce that threat. A very specialized administrative precaution that we use are environmental controls. So environmental controls are a set of practices that we use to actually change the physical environment of a healthcare facility or a workspace to be able to increase the safety at the healthcare facility and reduce transmission. And one of these environmental controls that we use that we're going to talk about today is, remember, these administrative controls for COVID-19, they're used to break the chain of transmission of the disease. And so we're talking about screening and triage today. Who can remind me in the chat, screening and triage will break what part of the chain of transmission? Can you write it in the chat for me? What part of the chain of transmission gets broken when you use screening and triage? I think I just gave you the answer. I accidentally tapped my button. Well, correct. So it is indeed, I see point of entry, community, transmission. Yes, it's the mode of transmission. We're really trying to use triage, which we can use as an administrative precaution to effectively assess the risk of patients coming into the healthcare facility. And if they have a huge risk, we want to make sure that we are minimizing the mode of transmission and reducing it. So always trying to go back to the basics here. Okay, so people ask me, but triage and screening are the same thing, Ebeth. We do one in the other, but the truth is they're actually very different processes, which oftentimes get used interchangeably in the IPC world. I wanted to give you a definition of the two, so that way we can start off our conversation knowing very clearly what are the differences. Triage is a process of sorting patients into priority groups according to their needs and resources available. So triage essentially is a way that we can rapidly identify and categorize patients based on their medical needs, obviously giving priority to patients who are in emergency situations. This is very different from screening. Screening is a process that we actually use to identify patients who are at risk of a given pathogen and that would maybe require additional investigation if there's a suspicion of infection or an intervention if it looks like the individual has the infection. Now, it is true in a triage bay or a triage area at your healthcare facility, you often do screening of patients to be able to identify what their risk is. Is that very clear to everyone, the difference between the two? Yes. So one is exactly, I'm very glad to see. So one process is really making sure that we identify priority patients, placing the most emergent patients as our priority group first. And then screening is actually looking to see if individuals are at risk of having a particular pathogen or disease. And if they are, we do further investigation. If they're not, and it looks like they have the disease, then we see how we can manage those patients. I just wanted to spend a little bit of time on this because I know that a lot of times people will say, oh, well, we're doing screening of COVID-19. And what they're actually doing is triage because they're using a triage form, which doesn't necessarily have some of the questions that we would want to use for COVID. So for example, we do triage at emergency departments, maternity clinics, and a lot of different healthcare facility departments. So we'll do triage to see if a patient is in an emergency situation, but really screening should also be done to ensure, particularly during an epidemic or a pandemic, to see if there are individuals who may be infected or suspected of infection before allowing to be entered into the healthcare facility. Excellent. Okay, I just wanted to make sure that we had clarity on terms, and I'm going to keep on going. So people then say to me, Ebeth, the triage area, what do I need to put into my triage area? I'm responsible at my healthcare facility, and I've seen ideas of what I need in order to effectively have triage set up at my facility, but I really don't know what it is I need. Well, here are the minimum requirements to set up triage. One thing I want to say is that triage and setting up triage does not have to be fancy. I have set up triage stations in a lot of different African contexts where all we used was 2 chairs and 1 table. If you and your healthcare facility does not have the resources to, let's say, purchase tarpaulin or other type of infrastructure or build a triage infrastructure, it's totally okay because triage is about the process, not about the building, okay? I always like to emphasize that. All you need is 2 chairs and 1 table to be able to actually implement triage at your healthcare facility. In that healthcare facility, you will want to make sure, in addition to your triage form, assessing patients for emergencies, you also want to make sure that you have a screening questionnaire with the case definition of COVID-19, which then screens more than likely syndromically for COVID-19. Now, the screening questionnaire may be a part of the triage form, or it may be a separate form. You also want to have an algorithm for triage form, the triage. You want to have 2 pathways into your healthcare facility. One pathway into the healthcare facility for those patients that you think are suspected COVID-19 patients, and one pathway for patients who are there to have other routine clinical services. You want to make sure that you have PPE for healthcare workers and medical masks for symptomatic patients of COVID-19, hand hygiene stations, infrared thermometers, tissues or pieces of cloth for respiratory hygiene, waste bins, dedicated cleaning and disinfection supplies. We don't want to use cleaning supplies in triage and then take them and use them in other areas of the healthcare facility. We don't want to potentially run the risk of creating cross-contamination. And we want to make sure that we have sufficient signs and posters so that way patients can know what they should do when they are in the triage facility. So there are 11 critical steps for establishing a triage station. So at each point of entry at the healthcare facility, you want to make sure that you can identify a space where you can put a station. If a structure like a building or a tent already exists at your healthcare facility, then you can use this space. However, as I said, if you don't have a specialized structure or a specialized space, do not wait to screen individuals at a triage station due to infrastructural limitations. If no structure exists, identify an area that has really good ventilation, preferably someplace outside, which can be used as a triage space. As I had mentioned, all you need is 1 table and 2 chairs to create a triage station. 1 table and chair can be for the health worker and 1 chair can be for the patient. You just want to make sure that the 2 tables are at least 1 to 2 meters apart. Patients who have COVID-19 symptoms should be placed in a separated seated area from patients who are not symptomatic. And again, seating should be 1 to 2 meters apart. So in your triage area, ideally it would be outside, weather and geographical considerations permitting. If you start to see that you have COVID-19 patients coming with symptoms, you would want to do your best to have them be separated from other patients who are not expressing symptoms. In your triage area, you want to make sure that you have sufficient screening forms, thermometers, hand hygiene, and PPE should always be available to healthcare workers, all right? You would also want to make sure that if possible, you maintain at least 1 meter distance from the healthcare worker and the patient being triaged if possible. If not possible, make sure that you're wearing the required PPE. Because I know a lot of times people say, but Ebeth, we have to take their temperature, so how can we be 1 meter apart? So I understand taking temperature is a part of a lot of the screening processes at a lot of healthcare facilities right now for COVID-19. That's totally fine. Just make sure that you're wearing the correct PPE to actually triage your patients. Ideally, an isolation space, which is close to your triage area or ideally attached to the triage area, should be established for those COVID-19 suspects. If it's not possible to establish an isolation space next to the triage area, then a ward at your healthcare facility should be designated the isolation ward. Again, based on your healthcare facility's resources and infrastructure, suspected cases may be further separated based on symptoms, mild versus moderate, so to speak. And again, you always want to make sure that you have 2 pathways. One pathway is going to be for those potential COVID-19 suspects who may need to be put into isolation. And then you would want to have a non-isolation pathway for those patients who are coming to the healthcare facility and need to go to other different clinical departments for care. And last but not least, the triage station should have a unidirectional flow. That means patients and healthcare workers go one way in and one way out of triage. You never want to go backward in triage because you don't want to run the risk of cross-contamination. Hand hygiene stations should be well established at each triage stations and readily available in the waiting areas where patients will wait to be screened. You want to make sure that you have waste bins, should also be placed at the triage station for hand hygiene and respiratory materials, and these items can be placed in the same bin. Security, if needed, should be available at each point of entry to guide patients, their support networks, and healthcare workers to triage stations for screening. In some healthcare facilities, we know that at the entryways at the healthcare facilities, they can become quite crowded, particularly during epidemics where a lot of people are going to the healthcare facility for care. If you find yourself in a situation where you need additional security or human capital or personnel to help guide people through the triage area into the healthcare facility, please do so. Is all of this clear? Is there anything that I stated that wasn't clear? I want to make sure that we understand the minimum package of what we need. Does everyone understand that these are the 11 steps for establishing triage and that there's just minimum requirements to establish a triage station? Are there any questions about what I've said so far? Clear to me. I like it. Clear as a bell. Okay, excellent. So PPE requirements for triage. Okay, yes, I will answer that question. I get that question a lot. Okay, excellent. Perfect. So what might this look like then? So what I've done is I have drawn a diagram of what a basic triage setup with all of the minimal requirements I just spoke about could look like. So as you see on the far left-hand side, you have the healthcare facility entrance, a point of entrance. As I had mentioned, it can be the ED department or the maternal child clinic. It can be an entrance to the actual physical healthcare facility grounds or the actual structure itself. And then of course, the first thing is you want to have your patient triage area. So you want to try to have ideally 2 areas where you have an area where it looks like patients might have COVID symptoms and an area where patients don't have COVID symptoms, respecting the physical distancing requirements for triage. And then you would want to have a triage chair, so to speak. So here's your 2 chairs and your table, your very minimum requirements. 1 triage chair for the patient, the chair for the health worker, and then of course, healthcare worker table with the various supplies that are needed. And then based on the screening that has occurred at the triage area for COVID-19, if it looks like the COVID-19 patient needs to be potentially admitted to the hospital or needs to be screened for further investigation, there's the isolation area. And then there's of course the non-suspect pathway to the other healthcare facility departments. I just put together this diagram pretty quickly just to give you an idea that this doesn't have to be a super complicated environmental setup. I wanted you to see that it's actually quite simplistic and can actually be done quite quickly. All right, excellent. Okay, well, I am going to move on now, and I'm happy to answer any questions a little bit later on now screening. So screening, as we mentioned, generally is looking for, in our case with COVID-19, when we're screening patients at the entry points of a healthcare facility, we're generally doing what we call syndromic screening or symptom-based screening, which is where we're asking individuals to self-report any symptoms that they may have, and we may be taking a temperature as well. So if you are engaging in screening at your healthcare facilities, I want to show you an example of a triage form that we've used that includes not only the triage information, so the priority patient information that we would need, but also screening questions related to COVID-19. So that way we can be informed as to which pathway we would want to make sure that our patient goes into as they enter the healthcare facility. So here is just an example of a triage form that has screening questions on it And the first information you're going to run into is basically just demographics, right? You're going to want to get information on when did the patient's symptoms start. And of course, if there's any previous medical history that is very relevant to the patient's care, particularly if the patient is in an emergent situation. Trying your best to collect that data as rapidly as possible is very important. The one thing I would emphasize is that this is an example of a triage form. I know that there are thousands of different ways triage forms have been created and or developed for various contexts and settings. That is totally fine. I simply show you this one just to let you know how triage and screening really work together hand in hand. The second session on this triage form is looking specifically at those symptom-based or syndromic questions we would want to ask the patient in terms of their overall symptomology. And then, of course, if possible, we would want to get a temperature as well as a pulse ox reading if we have those resources available to us at our triage area. We'd also want a little bit of history related to contacts and or travel history of the individual just to try to complete a more robust epidemiologic picture. And then sort of the third section is a history of, again, the contacts. We would want to then make a declaration as to whether or not we feel that we have strong enough suspicion as to whether or not this is a COVID-19 suspect. And then, of course, this is sort of the triage component of it, is that in terms of clinical status, we would then want to see, is this a critical case, a severe case, or sort of an uncomplicated moderate case? So there's the triage component of this particular patient's presentation. And then, of course, some form of actual referral. So if this is a COVID-19 suspect and it looks like they're in critical condition, we're going to want to really hurry and make sure that they go through the correct pathway and get them to emergency care and services. If it's not a complicated patient, but it looks like they still actually need to have medical attention within that day or the following day, trying to then follow the correct pathway and to make sure that the patient gets the care that they need within the next few days or so at the facility. Well, thank you so much. That's actually all of the information that I had for you today. I really just wanted to take a few minutes and to clarify some of that terminology and to give you just a few practical examples of some of the triage and screening content that's available in terms of making sure that you feel well saged to utilize these tools if you don't already have tools of your own to use. And thank you so much for your attention, and I'm happy to answer any questions a little bit later on in the and during the session. Thank you so much.
Thank you very much, Ibis. It was quite clear. I think there's quite a few in the question and answer box that we will keep for at the end that you could answer. I think we can move forward to introduce Professor Valerie Robertson from Zimbabwe, that's going to give us a country perspective from BRTI on the budgeting experience, how they've been working. So I'm going to hand over to Professor Val Robertson. Val, if you can please open up your mic and then you can start sharing. Thank you, over.
Thank you. Are you going to share my presentation?
You must just let us know if you want us to share or do you want to share yourself.
Oh, okay. I will try and share. Okay, good morning, everybody. I should have done what Ibis did before me and share my video screen. So maybe I can do that at the end. So I'm moving on to something quite different, but actually very important for developing IPC programs across the continent and everywhere, in fact. and that is budgeting for IPC projects. And this is from our experience in Zimbabwe. I'm from the Infection Control Association of Zimbabwe, but I've been working with infection control projects supported by the Biomedical Research and Training Institute. So we're looking particularly from a project perspective and not so much from a health facility perspective. Really because one of the challenges on our continent is that not many facilities actually have a budget for IPC programs. And where we start from is by initiating small projects, grow into larger projects, so that we can really strengthen IPC programs in all our health facilities. So I'm going to address it from that perspective. I'm not an accountant. I'm not a finance officer. I'm a microbiologist by background who's been involved in infection control for a long period of time. And we have had several IPC funded projects. And I guess I've gained a lot of experience in managing budgets and what we're supposed to do to make sure that finance covers the issues that we particularly want to address. So if you're looking at a budget for IPC development, we need to make sure that that budget can address the goal and objectives of a particular project, whether it's a very small project or a large project. You need to have goals and objectives. The budget needs to allow for adequate implementation of activities, so you have to plan activities carefully and make sure that you can acquire the funds that allow that implementation to occur. We also need to make sure, because we're dealing with other people's money, that that funding is dealt with properly, adequately. So we need administration for the budget itself and administration for the activities. Often it would help if we have funds to support the infrastructure, to support the project, but we also need to make sure that embedded in that administrative capability, we have a system to control and monitor expenditure. But we may be also, and we have to be aware of this, implementing activities maybe in other parts of the country, in facilities that will involve other personnel. So it's important that when we're implementing different activities, the people involved may be asked to plan a budget themselves. So we need to make sure that they know how to do that. So we'll go through some of these different issues very briefly. I only have about 10 minutes and we'll try and keep it short. But I hope this will help people who are trying to initiate IPC programs in their countries or even within their health facilities, that it will give them some idea of how to manage the funds or access, manage, and use the funds that they have. So a little bit of background from the Infection Control Association to give you some idea of where we're coming from. The association itself was established in 1993 to support IPC professionals. And as an association, we used to organize discussion groups. We sometimes had sort of more higher level workshops looking at IPC policy. We obviously introduced IPC training programs. Some were funded by WHO through the Ministry of Health, but we also involved local companies. So this was over a time period of 1993 to 2001. Then our economy collapsed and so did the association. And then we revived it in 2011. So from 2011, we partnered with other groups in order to bid for funds to develop the national IPC program. So I won't go into a lot of detail, but we were very fortunate. We worked with the Biomedical Research and Training Institute. We partnered with Management Science for Health, and then the TB Union for another project. With CDC, they helped us support a postgraduate diploma in infection prevention and control. And more recently, we've been working with RTSL to support training across the country in response to the COVID-19 pandemic. So across that time period, we've had a lot of experience in managing funds and how to use those funds adequately. So in developing budgets, it's important to have an overall goal for IPC development in mind. And I've just listed some of the goals that ICAS has outlined. It's supporting health workers to improve implementation of IPC programs, sort of ongoing support of IPC health professionals. We use WhatsApp groups and CME training, advocacy for the importance of IPC practice and programs in health facility and community, supporting the Ministry of Health to strengthen the national IPC programs. Those are just some of our goals. And it's really critical to delineate those goals so that when you look for funding, your approach, say, we have funds to help you do this, you're very clear about your goals, because when it comes to developing the project, you have to define specific objectives. They need to be smart. They need to be linked to your overall goal. But often they are linked to the source of the funds and the goals and objectives of your funders, which you obviously appreciate the funders, but their goals and objectives may be slightly different from yours. And so you have to work at marrying the two together. You can also look at previous projects that you have been part of, or even within the health facilities themselves, that identify the gaps that need to be filled and the way forward. And also you need to look at the national annual plan. And if you don't have one, it's worth working with your ministry to develop that IPC plan for development. It also depends on the capacity of your team available. If you have very few trainers on the ground, you may need to access international trainers, or the Infection Control Africa network may come in, or you may link up with other IPC associations in countries that border yours. So defining your specific objectives is an important exercise, but you need to be aware of the constraints and constantly aware of your goals. So under your SMART objectives that you've identified, they're measurable objectives, you then have to go and identify the different components of your activities. And I've just shown a couple of photographs here that describe very different types of activities that might be possible. Obviously, a major component is training. And this is one of our training workshops. I have to say that this is pre-COVID, so you won't see the spacing that we now require for COVID-related workshops, but it's just to show they occurred. But also you might access funding that improves the infrastructure of health facilities. Without water supplies, it's very difficult to support infection control programs. So one of the areas that really needs to develop in many of our health facilities are the wash components of IPC. And that just shows improvement of water storage at one facility we worked with. But also, as part of defining your activities, you need to identify staff and training requirements for implementation. And it's important that your staff are qualified to train, that they understand IPC programs, Ebeth talked about triaging. If you're going to use a trainer in COVID training and they don't understand the elements that Ebeth outlined, then you can't use them as a trainer. Because we have quite a lot of funding coming on board from very generous donors, we often incorporate people in our teams that really are not fully qualified. So it's important that we use our funding properly with properly trained personnel. And if they're not properly trained, we have to find a way as part of our activities to address that issues. And then I've just given you, I mean, many of you are probably familiar with budgeting, but this is really for those of you who are less familiar. So you would have to work out for a training, a workshop, for instance, the number of participants, the number of facilitators. Do you need to pay your facilities? What is part of the conference package? I put a little table that outlines the conference package. How much does that cost? How many days? I haven't put in the cost because they will vary across the continent. You need to accommodate your facilitators and provide per diem. So all those issues you have to sort out in developing your budget. But I'd like to say something about venues, because often we feel we have to have workshops in a hotel. This is how we started when we started our training of trainers programs. We started in hotels. And when we moved around the country, we moved to hotels. But then we realized that it's much better and also cheaper to have venues at health facilities. You're on site. You could maybe use your School of Nursing close to the health facilities themselves, and you can complete practical aspects of your IPC training because you can use the facility to take your participants and say, give them training in risk assessment. So budgeting, don't look at how much might be available. Look at how much you really need. Because if you spend less on the training venue, you can spend more on other activities. And these are just other examples of components of a budget that you need to include. So you're looking at transport costs. Are you doing site support visits? Are you funding your local teams, say provincial IPC teams, to go on site support visits? So this is where you need to train your provincial or district teams in costing their activities accurately. If they're costed accurately, you don't have complaints at the end that you've underfunded them, they're short of funds. You need to work together on this, and budgeting, believe me, should be a team activity. It shouldn't be the accountant who sits there and works out how much she thinks or he thinks everything should cost. It really needs input from all the team to develop these budgets. So you're looking at, for site support visits, you're looking at transport costs, overnight costs. Are they camping? Are they staying in a hotel? And critically, you need to have site support visit tools. And often it may be the project may need to print those tools, because our health facilities don't often have the paper, the cartridges for their printers to print the number of site support tools that you need. And then other activities. Again, I've just illustrated some of the activities we've been part of. We have a national IPC committee, and we supported the meetings. We developed a national policy. We supported the review of the drafts that were done. We've helped develop infrastructure, other IPC training material. We were part of developing a TB and NCD screening program. And obviously, all these require monitoring and evaluation visits, and it's really important not to under budget for monitoring and evaluation. And of course, we had the postgraduate diploma course, And one of our senior trainers, Ms. McGuenzie, is shown there talking to our IPC diploma students. And those are the documents that were a product of our collaboration with the Ministry of Health. So it's important when you're budgeting to identify all the costs that are required, that will be included in your budget, because sometimes you will have a shortfall at the end because you hadn't accounted for certain things. So I've just listed some of them here. Administrative costs, including bank charges. Depending on your banking system, you may find that your banking charges may be extremely high, maybe they're not, but could be. The institutional review boards. When we're doing IPC development projects, we think they don't necessarily need to go through an institutional review board, which we associate with the review of research projects. But because maybe in our project, we are dealing with health workers, and often our funders and your local institutional review board may want to look at the protocol to make sure that there are no ethical issues that you're not dealing with. So they're looking at human subjects protection. So IRB's costs, they usually charge, so you need to budget for that. Data collection costs is important, particularly projects, even in ministry IPC programs, you are dealing with data. You're dealing with indicator data, looking at IPC indicators that are important to monitor to make sure that your project is progressing and evaluating the quality of the IPC program maybe that is being developed. And then I think there's a slight typo here. So we have data collection costs for reporting indicators and costs for Zoom training, that should be. We're now doing much more training on Zoom. So if you're looking at larger numbers, you need to look at your Zoom registration. And then, of course, there are procurement costs. We use the 3 quotes principle, and I'll say more about that in a moment. But we need to include services, maintenance of equipment if we have that. And then if for us, we work with BRTI, they have an institutional levy. And so you have to incorporate that into your budget. So I've just listed these other direct costs on the right, and it's just extracted from one of our budgets, just to give you an idea of what you should include if you have a big enough budget, of course. So I'd just like to say a little bit about the challenges of budgeting. It's very difficult to be precise. And often in the area of IPC, our budgeters lack experience in what it costs to do site support visits, what it costs to procure the different consumables for an IPC program. Also, everything takes longer than you think it's going to be, and you may have a limited time period for using your funding. So time sensitivity is often a challenge. Staffing, we've discussed. Finding a funder is a challenge for everybody. And linking funders to your objectives is also a challenge. So some solutions from our experience, of course, you evaluate what you've done in the past and you learn from previous experience. Training on budget development is very helpful. Some of our funders have provided training and that really helps in addressing the challenges. Local support, other people with experience can help you. But teamwork, I cannot stress more the need for teamwork in budgeting and planning. Well-qualified staff, if they're not so well qualified, I mentioned initially that we need to identify gaps in experience and develop a training plan. But also we tend to depend on external funders. It's important to source local funding and also monitor funding opportunities for the international funders. If you're starting small, then local funders are invaluable in helping you develop a small workshop or a discussion session or a small continuing medical education session, say on triaging. If you want to do something for a group of people outside the health facilities, then local funding would help you. Even in poor economies, you will find someone who will help. But always be clear on your long-term goals. The management of the budget is really critical. You have to make sure that you comply with the labor laws and the tax authority. I think that's fairly obvious. But also it's important to have standard operating procedures for budget management, for procurement of services, equipment and payments, and just to ensure integrity of the system and use of funds. So anyone funds you can come in and say, how have you recorded your financial activities? And these are just a couple of forms that we use for procurement, a comparative schedule, which I think many of you are probably very familiar with. And then just further develop a payment approval system. We have quite a complex one. So before you make any payment, you need to go fill in the forms that provide approval for that payment to be made. So it goes up through different layers from the project manager up into the finance department. But it's also important to monitor your funds, documents, funding expenditure against line items in the budget, monitor percentage usage on a monthly basis. Sometimes if your initial budget was not accurate, you've got more on one line item remaining, but you need something on another line item, you request for redirection of funds. And that's usually possible, but you have to give justification to do that. And then reports obviously are important, but also include, and I think this is a mistake we made earlier in the program, ICAS program, we never budgeted for funding for an audit to be done. We thought we manage our funds well, properly recorded, but any outside funder wants to look at your financial record, and a regular audit goes a long way to establish that financial record, and it's important. And this is our association with BRTI for us. They've been extremely important in helping us manage our budget, but also they have regular audits, which satisfies the funder. So this is my last slide. So that our goal in terms of budget is to improve the quality of IPC programs in Africa and contribute to quality healthcare. And from your passion for IPC, because we're presuming all participants in this webinar come on the webinar because they have a passion for IPC or they want to learn more. So you need to develop a clear vision for your facility, for your province, for your district, and for your country, and define a strategy for IPC program development. But also, you don't need to stop and say, no, I don't have these big funds. I need all this money to start. Build on no-cost activities. So you have a discussion group within your health facilities. You take eBest training on triaging into your health facility and have a session with the staff on the ground. It demonstrates the passion to strengthen IPC activities. And if you document that, if you have regular documentation of IPC activities, it really provides information for those who might want to support you, that you mean what you say in terms of you want to develop IPC and you're actually doing something. You're not waiting around for somebody to drop a pot of gold in your lap. It's extremely important, I think all of us know this, to work closely with the Ministry of Health, because there's little point in developing little silos of IPC development in small facilities without really building into the national plan. So this working closely with the Ministry of Health is important. And as I say, start with small activities, a workshop or a discussion group, plan carefully the budget carefully, and be precise as you can, recognizing it's not always possible to be totally predictive of what costs are going to be. But it's really critical to develop a transparent, ongoing, and accurate system of accounting and financial reporting. A funder will not refund you, may even stop a project if that process is seen not to be functioning. But also, I talked about the goal. It's important to target your funds to activities that will have a meaningful impact. Otherwise, to me, it's a waste of time. But I've talked about projects, but what we should really be working towards, and what the person who should really be talking about budgets, is those who are setting up IPC programs in the Ministry of Health. That we need to advocate for IPC budgets within health facility budgets and also at national level. I feel very strongly about this. My teammates in ICAS and BRTI also, that we need this type of budget across the continent. So there are my acknowledgements, and to our funders, to the Ministry of Health, and to all the staff we've worked with. Without the funds that we've been given, we wouldn't have accomplished all the IPC progress that we have. So thank you very much, and I'm happy to take any questions in the panel discussion.
Thank you very much, Professor Robertson. I think it was great to see this. It really allows people to think about when they want to move forward. I'm going to go forward with the question and answers because Dr. Alemi asked me to take that on. So I'm going to open up the questions, and I'm going to start at the top so we can get some of the answers that people are asking. Can I just ask, please don't raise your hands or put it in a chat box. It's not possible for us to address that. Rather, just put it into your question and answer box. I saw that Yolanda raised her hands. I'm not sure, Yolanda, what do you want to ask? Maybe before we start with the questions, Yolanda?
Sorry, no, that was a mistake.
Okay. So for the participants, if you do want to ask anything, please put it in the question and answer box. We've got half an hour or 25 minutes to move along with these questions. Some of them are similar, so I'm going to try and see if we can answer as many as possible. The first question that came in just after we started wanted to know what comparison can be done as far concerning the evaluation of current pandemic. Do you think still is more to come? I think that will be for Patrick, but I know that Patrick has left, so maybe I can ask Silas or even Prof. Robertson to answer that if they think they do have a no, they want to know what is the comparison done so far about the evaluation of this pandemic, and do we think there's still more to come? Silas?
Yeah, I'm here. I'm just trying to understand the question. Which one? Maybe if I can find it in the chat box.
It's the first one in the question and answer, not in the chat, in the question and answer box.
Okay.
First one on top, you will see there's a question that they posted. They want to know what was the comparison done as far, and I think that was more for the epidemiology, but maybe some of the
Yeah. I mean, I can only answer in terms of what I've seen and what I've been reading. I think this pandemic is not going away. We've seen the development of new strains of SARS-CoV-2, the South African strain, the Brazilian strain, and now they're popping up all over the place. And mainly in places where they have the facility to type the isolates. So, for instance, in Zimbabwe, we think we've got the South African strain because South Africa is so close to us and we had a second wave and it seemed to spread very quickly, but we haven't as yet, and it's going to happen. We haven't typed our strains to determine what's there. So I think that's all I can say about that. I think the way it's developing, we just still have to be constantly on the alert, even with vaccination programs coming in. Not everybody is vaccinating. So the IPC elements that we all familiar with, hand hygiene, wearing of masks, social distancing, are still going to be critically important for a long time to come. Thank you.
Thank you, Professor Robertson. Yes, I totally agree. I don't know if anybody else wants to also comment on that. Amy, you raised your hand.
Hi, yes, this is Ebeth. So absolutely agree with Dr. Val that this is going to be something that we're going to be dealing with for a very long time. And I can give you a little bit of a perspective, if you will. So 1918 Spanish flu, which happened a century ago, it took the global community about 6 years to actually get rid of that pandemic from start to finish. Now, before everyone completely loses their mind and says, Ebeth, my God, please don't tell me we're going to be dealing with this in 6 years. What I would just like to say is that, you know, that was 100 years ago. And obviously we have a lot more resources, a lot more information, a lot more technology, and a lot more science than we did 100 years ago. Nevertheless, even with all of that, this isn't going to go away tomorrow, but I am optimistic that it won't take us, hopefully, 6 years to get rid of this particular pandemic just because of the reasons and the resources that I just mentioned. But I would really like to reemphasize that just because we start to have vaccines and potential other therapies that may be coming down the pipeline, you still must go back to the basics. And to really reiterate Dr. Val's point, there really is no replacement for hand hygiene, physical distancing, and wearing the appropriate PPE when you are out in the community and or working in your healthcare facility. Over.
Thank you, Amy. I want to move on to the next question, and there were quite a few questions about infrastructure. The first one asks, COVID-19 triage, is it the same as Ebola? And Amy, I'm going to direct this to you in terms of infrastructure, if you would just quickly want to answer that.
Mm-hmm. So the key tenets and the key principles of triage are more or less similar, irrespective of the pathogen. So the triage system that you see for COVID-19 will look very similar to the triage system in space that you would want to put in place, let's say for a hemorrhagic fever. One of the critical distinguishing features between the two pathogens, if you will, for those of you also worked, Ebola epidemics, is that really there's greater emphasis on the physical distancing in COVID-19 triage areas. We really want to really make sure as best as we possibly can are keeping that 1 to 2 meter distance, given that this is a droplet precaution. So that's one of the sort of key infrastructural differences. But in terms of the key components of triage, those don't necessarily change based on the pathogen. What also changes is, of course, the PPE requirements. So obviously the PPE requirements for COVID-19 in triage are going to be very different than the PPE requirements for a hemorrhagic fever at triage. So those are some of the key distinguishing features, but in terms of key principles, those are going to remain more or less the same.
Thank you, Edith. I don't know if anybody else wants to elaborate on that. I think it was quite clear. Then the next question, Amy.
Sorry, Anna.
Yes,
Sorry,
Carol.
Anna. Can I just add something here? Because it's important to understand the differences between the two different pathogens and the different requirements for PPE that Ibeth mentioned. Because many of our health workers may have had excess stores of PPE for hemorrhagic fevers because no one with hemorrhagic fever turned up in their country. They've got these stores, so they bring them out. And everybody's using hazmat suits, which in every situation, which is not the PPE policy we recommend. So it is important that we help our colleagues understand the difference between the two in terms of PPE.
Thank you, Professor Val. Yes,
Thank you, Val. Thank you.
Yeah, very important. I think that's something that we really need to understand. There's a lot of questions about this and isolation, and I think we need to understand the difference between the two different diseases. So one of the other questions, Ibeth, for you was they were looking at new infrastructure design, and they want to build in screening booths. They want to know what is the minimum requirements. We already include triage spaces. I don't know if you want to maybe answer on that.
I do apologize. I'm not sure that I understand the full extent of the question. In terms of the minimal requirements for triage, I did review that in the presentation. And then, as you can see, I mean, for the most part in triage, ideally you would want to have, in terms of respiratory waiting areas is maybe what the question is asking. I mean, in terms of the respiratory waiting areas in your triage space, the same principles that we've been talking about still apply. You know, a hyper emphasis on making sure that you are distinguishing those individuals who have symptoms from those who do not have symptoms, making sure that all individuals, particularly during this very acute time during the pandemic, everyone who has symptoms, and even one could argue potentially those who don't have symptoms who are coming to triage, wear a mask. And then ensuring that there is physical distancing of, you know, chairs or waiting area spaces while patients are potentially waiting to be triaged and to be screened. I don't know if that answered the question.
I think what they wanted to know is about the screening booths. They want to include that. They've already got the triage spaces, but they want to include the screening booths. I think that's where they want to have the minimum requirements for that.
What are the requirements for a screening booth? I mean, really screening, you need nothing more than really just your form and a writing instrument. I mean, it doesn't have to be something super sophisticated, which is what I really wanted to emphasize in my presentation, is that you can do screening and have just the actual form and a pen. So, you know, you don't have to have a specialized screening space or a screening booth per se. Yeah. Okay.
Thank you. I think one other thing that a lot of questions came around the social distancing, 1 meter, and in other countries say 2 meter. They want to know if they need to increase that, or what is the standard. And you know, we know that WHO and on Africa CDC are on the website that as well, there's guidelines. So if you can just maybe reiterate why we're saying at least 1 meter. Thank you.
Yes, so we're really, the WHO and Africa CDC have put out their guidelines, and there has been suggestion now that we would like to say 1 to 2 meters if possible. And the reason we say at least 1 meter is to make sure that you at least have that much distance between you and another individual. So 1 to 2 meters would really be apt. I know that there are some countries that are trying to be more conservative and err on the side of increased safety and saying 2 meters. That's perfectly fine. but at least 1 meter is really what's still the solid recommendation. But I would say probably 1 to 2 is fine, just giving some of the evidence coming out. But for the most part, if you have at least 1, you're going to be okay. And if there's additional data that's coming down the pipeline that suggests that we need to increase that, well, then that would be something we'd have to definitely follow up very closely with our risk-comm teams. Over.
Thank you, Edith. I don't know if anybody else wants to comment on that on the panel.
No, I think Edith has answered the questions.
Okay. This one I want to give to you, Professor Val. They were asking, they say, thank you for the presentation. Do you implement community IPC in Zimbabwe? Can you share your experience on that? Mr. Val, just unmute yourself.
Sorry, I was just trying to look at the question. So is this is a question addressed to Amy at the isolation area. What IPC is there?
No, they wanted to ask you, do you implement community IPC in Zimbabwe? And if you can share your experience on that. That's not the,
Okay.
Sit down the line.
Okay, we have a huge community program. Whether the community always addresses the recommendations is, I think, the same across the continent. But we have a number of pillars that are part of the Zimbabwe response to the COVID pandemic. One of them is there's an IPC pillar, and we have developed documents for advising communities about infection control issues. So that's wearing of masks, how to manage family members at home, what you should have put in place to reduce risk of infection. But we also have a risk communication pillar who are continually targeting messages within and at the community to really address the components we've already mentioned, wearing of masks, social distancing, and hand hygiene, hand washing. So there's a lot of community work going on. Is it totally adequate? Of course, we all want to improve our responses. And we went through a phase where we had what was really quite a small peak in the initial stages of our exposure to the virus. And numbers went right down. And then the community became very complacent. We opened schools, and then we had, then suddenly the second peak began to appear. And people began to realize, no, it hasn't gone away, and we still need to adhere to the recommendations. So in a way, community involvement is a continuous process. And it's the same with our health facilities. You can't have a training and then stop. We have to look at implementation and really encourage people all the time, continuously, in different ways, to implement the IPC requirements. Thank you.
Thank you very much, Professor Val. I'm going to open up this one to anybody, and that could be Edith, Professor Val, Lizzie, Silas, or anybody, or even Yolanda. They want to know, they say, we seem not to be doing well in disinfection of premises in case of COVID-19. There's still a lot of spraying using chlorine in my country. What advice would you provide? Over. Who do you want to answer on that?
Can I come in there?
Yes.
And I'd be glad of other people contributing on this issue because it is a very controversial issue. One of the challenges we've had is that a pandemic response is usually managed by our environmental health. Outbreak response is managed by environmental health. And sometimes they have ways of approaching infection control that are different from the way an IPC program would manage infection control. And this is made evident by this exercise of spraying everything in sight, buildings, people. And spraying people is dangerous, and it's not a WHO recommendation. In fact, the Africa CDC and WHO and ICANN came out with a statement about spraying, and that people can suffer health consequences, which actually could damage their respiratory tract and their response to COVID-19. So it is a serious issue. To be honest, some people say it makes people more secure. Our environmental health people say, well, they're disinfecting areas where healthcare workers work, so they're reducing the amount of work they do in environmental cleaning. So I think the resolution of this is really to work with our environmental health colleagues and look at evidence-based practices, which we always recommend, and sometimes the evidence is not clear, but at the same time, a discussion between colleagues coming from different perspectives is really important in resolving the issue. And I think this is ongoing. To begin with, at the beginning of our outbreak in Zimbabwe, our health workers were all demanding hazmat suits and to be sprayed. So that is gradually disappearing. So I think as people become more confident, as our messages become clearer, then we can share some of the practices too, which to my mind mop up money that could be used for purchasing more PPE. But that's a personal point of view, but our IPC pillar is very clear about the lack of value in spraying buildings and floors and whatever. Thank you.
Thank you very much, Prof. Robertson. I don't know if anybody else wants to also say something on that. Aria or Amy or Celestina or Silas? Doesn't seem like it. Can I take the next one? Edith, they said to you, maybe you can just answer that. They said they're good presentations, but just suggesting that we kindly describe the ambulance access to and from the triage and maybe the importance of ambulance flow from triage to isolation unit. Do you want to say anything on that, Amy or Edith?
So the question is, I just want to make sure that I understand, is how should ambulances be presented to triage?
Yes, and also how they can look after themselves going to the triage and the isolation unit.
Okay, so generally if you're arriving in an ambulance, your triage procedure is going to be that someone's probably in an emergency situation, unfortunately, right? So if you're coming from the community and you're arriving to the healthcare facility in an ambulance, it's pretty safe to say that you're probably having a severe or a critical health emergency. So you would want to do as best as you can and as best as your patient's ability to answer and respond to your questions. Try to do the same screening if possible. Again, an emergency is an emergency. If a patient is non-responsive, then clearly you have to see to the emergence situation at hand. And then when possible, try to then have the triage form with the screening tools then potentially then assessed at a later date. But, you know, it's the same sort of set of principles. An ambulance is going to present itself to the ED. The healthcare workers that are there should have the appropriate PPE on and be ready to sort of receive the patient that's going to be coming from the ED. Obviously, the technicians and the driver of the ambulance should already have the appropriate PPE on in order of taking care of the patient, and then the patient should be rapidly moved and triaged from the, the ambulance into the emergency department or whatever department facility that the patient will be moved into. If you can ideally still do triage while the patient is in an emergent situation, wonderful. If you can't, obviously the emergency takes precedence.
Thank you, Edith. Ario, I'm going to ask if you or Silas can maybe answer this one. they said there's a challenge in the lack of IPC equipment in locally because the equipment is ordered internationally. For example, the gloves, the screens, the facial mask, and all of that. They want to know if there's opportunity to have equipment made in Africa or use locally material to make the IPC. So I will hand that over to you, Ario and Silas, if you can maybe just answer on that. Please unmute yourself. Ario? I don't know if there is a problem with them. It doesn't seem. I know that they were working on this, and there is a organization that were formed, and they were looking at all the locally manufactured and getting equipment quicker. If you visit the Africa CDC website, you will be able to see the guidelines and all the information about that. So please visit the Africa CDC website, and you will be able to see what they've done. And I know they've done quite a lot on that already. So if that would answer your question, you will be able to see it there. One thing that maybe another question Prof. Robertson and Edith or anybody else can answer. They said sustainability is a problem in the low to middle income countries. How can this be addressed in budget, and costing is also a problem because they experience so there can be no sustainability. So what can they do about that? How can they address the budget and the costing issue in a low to middle income country and also get management involved? Over to you.
Maybe I could start and then Edith from her experience could add on. I know from our perspective here in Zimbabwe, what we've done in terms of trying to build sustainability into the program is develop structures that are responsible for that program. So our Ministry of Health now has a national IPC committee. It's recently appointed a national IPC coordinator. That committee has 3 technical working groups, one for training, one for infrastructure, and one for surveillance and monitoring and evaluation. Do they function perfectly? No. Particularly because COVID has sort of interrupted that development. But they are there, they're recognized by the ministry, and we're using them to implement further developments. So structures are important. And then one thing we've done in terms of budgeting, not totally fully successfully, but in our training, we encourage facilities to have an IPC budget. And it's not necessarily finding more funds. It's using funds that they have, that they may be already spending on disinfectants, on cleaning materials, on PPE, but they sort of pull bits and pieces from budget line items. What we recommend that they do is consolidate these bits and pieces into an IPC budget, which means your IPC team or your focal person have a budget to rely on. It may be very small. One of our hospitals set up a budget of 2,000 a month. Mm-hmm. And that was really helpful, and they made a lot of progress in making sure environmental cleaning was done properly and maybe acquiring some PPE. So it's just a question of advocacy and encouraging our ministries of health to not necessarily find new funding, but corral that the funds that they do have to target at IPC. And that begins with recognition that an IPC program is essential for quality care. Thank you. Maybe I can hand over to Ebeth.
Thank you, Prof. Roberts. Edith, do you want to say anything?
Yes, I mean, I think one of the things that Professor Val highlighted earlier too, that I would always like to just emphasize is that look at those non-cost or sort of I hate to use the term, but the low hanging fruit or the minimal cost things that you can do to really ensure the safety of your healthcare workers and patients at your facility level. A lot of the IPC practices, particularly the administrative ones, are very no cost or very low cost. I mean, it doesn't take a ton of funding to, print copies of a screening form, right? And things like that. There are lots of different ways that you can actually successfully implement IPC practices and not have to completely wait for sort of, like Dr. Prof said, Dr. Robinson said, a pot of gold, particularly when it comes to those administrative precautions. I mean, as you see today from the presentation, you can set up a triage area with very minimal resources, and the cost is really, really, really minimal, but the overall prevention that one gets from having such a low cost investment at their healthcare facility is pretty surmountable. So I would just encourage you to really explore those types of IP precautions that you could implement, today or tomorrow, that really don't have to be, huge in financial investment.
Thank you very much, Ebert and Professor Vell. We are reaching our time, so unfortunately won't have time for any more questions. If you do have any more, and I saw there's quite a few that's actually not for this platform, but you can contact Africa CDC or ICANN on private mails to see if we can maybe help. We want to also invite you for the next session next week, Wednesday. Also to remind you that every week Friday there will be a French session, and the flyer will be going out to all the people on our list. And every day on on the English versions, we will have translation into Arabic as well for the people that is on the call. So I want to thank all of you and thank you for the great presentations. All the presentations will be shared to the people that registered for this. And please, the series runs over until 24th of February, and then we will start a new series. So please look out for this, and if you want to participate, please contact Africa CDC or ICANN. Thank you for your time, and thank you for the time here. Goodbye.